My name is Robert Emery. I am a private practice oral and maxillofacial surgeon in Washington, D.C. Today I'm going to be talking about digital treatment planning and in particular image acquisition. Please remember whenever you're treatment planning, whether it's analog or digital, that implant planning is top down. It's restoratively driven and that your accuracy is only as good as your plan. Doesn't matter what kind of guidance you're using, static or dynamic, you're only as good as your plan. And your ability to plan is determined by your ability to see while you're planning. So what are your options for imaging? You can use a CBCT alone, a CBCT with an imaging guide, or a CBCT with superimposed STL file. CBCT alone, the advantage are it's easy. There's no lab work, but there's significant limitations because of artifacts in older patients, both in the quality of the bone and a large number of metal restorations that are often there. CBCT alone is not always appropriate. You can't see occlusion with the CBCT because you need to have the mouth open in order to use an X-clip. And you can often not visualize both restorative margins and soft tissue margins. This is an example of an excellent use of a CBCT alone. It's a young patient with a single missing tooth. You can see they've used a virtual tooth, which is available in the XOS or the X-Guide software. This is useful for young patients and one or two units where you have mesial and distal dentition, which helps you determine occlusion and the shape of the arch. Always use a cotton roll, and that way you can see the soft tissue margins. And again, you can use virtual teeth. This is an example of an older patient with a large metal restoration. There's significant artifact. There was a cotton roll used. And so you can see some soft tissue detail, but you really can't see margins of restorations, detail occlusion, and detail marginal restorations. A CBCT with an imaging guide. The advantages are you can see soft and hard tissue margins, you can visualize occlusion, and you don't need a laser scanner. What are the limitations? You need to do a little bit of lab work, and X-clips can often not be placed on top of Essex type's imaging guide in distal cases. CBCT with an imaging guide. In this case, you can see this is the ortho case. The restorative dentist, Dr. Poggeman, made did a wax up on a model and put a denture tooth in there and sent that to the orthodontist for space management. And then it's going to be used to fabricate a radio-opaque imaging guide. You can see in this case, the area the X-clip is going to be placed has been cut away. So this is an example of where an Essex type imaging guide is ideal because you never want to put a X-clip on top of an imaging guide or any restorative provisional because it moves. This is that patient with the CT. You can see soft tissue margins. You can see in the CT, in the cross section, you can see the tissue thickness, ideal Pontic placement. So this is an Essex type imaging guide. We've cut away the area for the X-clip. The soft tissue, again, you can see because they put a cotton roll in place. Got detail, occlusion, and emergence profile, and you can, again, use virtual teeth. This is another example of Dr. Poggeman's work. He's done full contour diagnostic wax up. He does a silicone matrix, and he's making Essex type retainers. He's using thick material, and you can see he's exaggerated the contacts. So when the CT is taken, you can see the contacts. And this is again example of restoratively driven top-down example. You can see the exaggerated contacts can easily be seen on the CBCT, and it's going to be no problem determining where the restorative dentist wants the implants. CBCT with an imaging guide, the limitations are you need to do some lab work. and the XClip can prohibit the use of imaging guides, particularly in bilateral posterior cases. So CBCT with an STL file superimposition, what are the advantages? You can visualize soft and hard tissue margins. You can visualize occlusion. There's no need to do or minimal need to do lab work. XClip does not interfere with it. You can use any restoration that's in place, either fixed, provisionals, or an Essex, or a flipper, partial denture, or a full denture. And you can use it with virtual teeth. What are the ways of obtaining an STL file? You can use an intraoral scanner, which is the easiest. You can take impressions and send the impressions with a bite to your lab, and they can get you your files. You can take a CT of a model and use the software in the XGuide to convert to an STL file. And you can take a CBCT of the model and use a laser scanner to create an STL file. It's important you understand what an STL file format is. It's a stereolithographic file format native to stereolithographic CAD software. It was created by 3D Systems. STL files, or STL, has several after the fact backronyms such as Standard Triangulation Language and Standard Tessellation Language. This file format is supported by a lot of software packages in implant dentistry. It's widely used for rapid prototyping and 3D printing and computer-aided manufacturing. And what's very important is STL files describe only the surface geometry of a three-dimensional object without any representation of color, texture, or other common CAD model attributes. In other words, it's only the surface. It does not just show you a volume. These are examples of different intraoral scanners that are available. The iTero, the Trios 3Shape, and the Condor, which is not yet available for full arch, but will be soon. All labs have desktop scanners, and what you do is just take impressions, send the impressions in a bite to the lab, and they'll send you the STLs of the maxilla and the mandible and occlusion. And they normally don't charge a lot for this. The ways of obtaining STL files from a model: you take an impression, pour the model, take a CBCT of the model, and use the DICOM conversion tool in the XGuide software to convert it to an STL file. You import the CBCT of the model into the XGuide software, you define the arch, and then you export the model as a bone mesh. So here's an example of the same patient I showed you before with STL file from an intraoral scanner superimposed on the patient DICOM. You can see details of the soft and hard tissue. You can see the detailed occlusion, and there's no lab work at all. So this is a patient who was recently referred to me for implants in 5, 9, 10, 11, and 12. The patient's wearing an Align retainer with Pontics in it. Cannot use a laser scanner on the Essex retainer with an XClip. So how do I use this provisional with an XClip? In this case, my staff just took an impression of the patient with the Essex in the mouth, and we're going to take a CBCT with an XClip on the patient without the Essex in place. We're going to take an impression of the Align retainer in the mouth and pour a model. And then we're going to take a CBCT of the model and convert it to an STL file. Or we can take a laser scan of the model and convert it to a STL. In this case, I took a CBCT of the model, I imported the CBCT of the model, and I'm defining the arch in this screen. Next, what I do is I export the bone mesh. This tool exports the model as an STL file, and then I will import that STL file or the bone mesh back into the CBCT of the patient with the XClip, and I'll superimpose it using the superimposing software. But something you need to remember, and one of the disadvantages of Essex type provisionals, is you need to remember the Essex retainers are not the tooth surface. The STL file are surface meshes, And it's difficult to superimpose them onto the CBCT because you need to account for the thickness of the Essex material. What you can do is use seating windows to identify the tooth surface. So you take the Essex, drill a few holes in the occlusal surface, then put it in the mouth and take your impression, and then you can use those holes for superimposition because you can see the tooth surface. So in this case, I am superimposing the STL of the impression of the Essex retainer onto the DICOM file of the patient with the STL superimposition tool in the X-Guide software. And then I'll go ahead and plan the teeth using virtual teeth. Or, in this case, I can just use that STL file. And you can see the detail that's available, and you can even have occlusion. So how about with dentures? With the edentulous patients with a denture, we use a dual scan technique. You take the Suremark 2mm sticky fiducials, which come in rolls, and you put it on the surface of the denture. You take a CBCT of the denture. You surgically place your edentulous fiducials in the patient, either before or during the day of implant placement. And you take a CBCT of the patient with the denture and the sticky fiducials, and you import the patient CBCT into the X-Guide software, and then you import the CBCT of the denture. The X-Guide software, when you import the CBCT of the denture, it automatically converts the DICOM of the CBCT of the denture into an STL file, and the software automatically superimposes that STL file onto the DICOM of the patient. You don't have to do anything. So in summary, the image acquisition options are: always remember this is top-down planning. It's no different than any other implant planning. Your accuracy is only as good as your plan. Your plan depends on your ability to see, and your imaging options in order to see are a CBCT alone, which are limited, a CBCT with an imaging guide, a CBCT with a superimposed STL file, and you can either use an intraoral or lab scanner to get the STL file, or you can take impressions, take a CBCT of the model, and convert the CBCT of the model into an STL file. I hope this information is helpful in your treatment planning, and again, remember, your treatment planning is only as good as your ability to see.